Good evening. Thank you, Dr. Namrata, for the opportunity, and thank you, AOS, for the honor of the platform. I am Dr. Radhika from Shankar Nethralaya, and I'm going to be talking to you today about collagen cross-linking treatment in microbial keratitis. Collagen cross-linking treatment, as we know, has been the standard of treatment to halt ectatic disorders like keratoconus. It also confers an antimicrobial effect, which is being put to use in microbial keratitis. The ultraviolet light damages the RNA and the DNA in the chromosome of the organisms. The reactive oxygen species, which is liberated because of activation of the riboflavin, seems to destroy the cell wall of the organism, and the built-up tensile strength of the cornea gives more resistance to collagen-lytic enzymes from the invading organism. So that is how CXL works for corneal infection. So what is PAC-CXL? PAC-CXL is photoactivated chromophore CXL for microbial keratitis. So how different is PAC-CXL from CXL that is done for keratoconus? Well, it is not different at all. The two names have been given for the two procedures in order to avoid scientific confusion due to CXL being treated for two widely different entities, namely keratoconus and microbial keratitis. PAC-CXL has been employed against various organisms. There are many protocols that have been followed, starting from the standard Dresden protocol to the ones which obey the laws of reciprocity, which shorten the duration of the treatment with as much effect. And there are also cheaper options as well as ones which with lighter equipment, like CXL, which is done on the slit lamp, as well as with handheld devices which are being studied. PAC-CXL seems to work well in moderate bacterial keratitis and in small fungal ulcers. The effect against acanthamoeba keratitis seems to be variable, as my previous speaker pointed out. And at the present time, there is no role for any kind of CXL in viral keratitis, because we know that it can unmask or worsen the condition, so let's not even go there. When PAC-CXL works, it definitely would reduce the drop toxicity because of the compounded medication that we use for infective keratitis, and also it would mitigate the need for surgery. But we must remember that CXL of any form works on the anterior layers of the cornea. So when there are deep ulcers, they will not be affected by PAC-CXL at all. Especially in fungal keratitis, there seems to be a tipping point, a point where the fungus which grows along the layers of the cornea suddenly starts migrating into the cornea. This is quite commonly seen in people who have been inadvertently treated with steroids earlier. So in these kind of progressing fungal keratitis, PAC-CXL may not have value at all. Below in the panel, you see a patient of moderate fungal keratitis in our institute having been treated with PAC-CXL along with antimicrobial therapy, who later scarred down completely. So after the tipping point, when fungal keratitis, or for that matter, any ulcer progresses to this level, then what do? This calls for, I'm sure all of you will agree with me, a therapeutic PK, unless we are lucky enough, like Dr. Namrata Sharma, to inject and make this resolve. So otherwise, the goals of therapeutic PK will be to eliminate the infection and to reestablish the integrity of the flow. And therapeutic PK in very advanced corneal ulcers carries a high chance of recurrence. Recurrence can happen either because the duration of the disease has been very long, or the organism is very virulent, or the medication is not working, or the patient is not compliant with the medication, or during surgery, infection has been left back. So whatever be the reason, when recurrence does happen, it negates the goals of the therapeutic PK itself. So we were wondering whether we could employ CXL, which was used in PAC-CXL of a keratoconus, to reduce this recurrence of infection in microbial keratitis. So we know that CXL has been used in the donor carrier cornea in Boston keratoprosthesis, because this is where biological tissue meets with plastic, and therefore collagenolisis can happen in a sterile fashion, and the fortified cornea seems to withstand this better. So we try to employ the same principle where we check if organism or infection-induced collagenolisis can be retarded by a fortified cornea. Here, the biomechanical strengthening effect of the cross-linking was being used. So what we actually did was to take the donor cornea before therapeutic PK, and according to the Dresden protocol, do cross-linking on it mounted on an artificial anterior chamber. This was done for severe corneal ulcers, which required therapeutic PK. So basically, the graft was cross-linked just before the treatment. We avoided doing this in patients who were dependent on one eye and patients who had perforated corneal ulcers, or those who had other comorbidities, severe infections like pythium keratitis, the ones which we have not still unraveled completely, or those in whom there were extensive exudates either behind the cornea or in the anterior chamber, or those which had extended to or beyond the limbus with extensive scleral involvement, because we didn't know whether this procedure will work or not. However, the ones who were included, barring these, did have severe infection which needed therapeutic PK. So what did we see? The main outcome measure, obviously, what we looked for was whether the infection recurred or not. And we were pleasantly surprised to see, compared with a set of controls, the eyes which underwent TPK with previously cross-linked donor cornea did show less chance of recurrence. However, this was not without issues altogether. So we all know that cross-linking works best with de-epithelialization. The variant in which the epithelium is left intact does not seem to have that much potency. We've seen that with keratoconus. But here, in the context of therapeutic PK, it is definitely not prudent to de-epithelialize the cornea. I'm sure the panel will agree with me. So what we did was, luckily, because these therapeutic grafts are usually reasonably second quality grafts which have been in the medium for a longer time, so usually they will have some amount of loose epithelium or little cracks in the epithelium. So we made use of that for the dye to penetrate inside. Also, these grafts, for the same reason that they've been in the medium with little loose epithelium, would have swelled up a lot. And we do know that the cornea swells, the effect of cross-linking is quite superficial. So that also needs to be contended with. And when the infection recurs because of exudates in the anterior chamber or from the angle, then it's coming from within. And no amount of CXL would be able to retard this infection getting into the donor tissue again. So that was a concern. And last but not the least, the post-operative medication. We know that there are studies underway which show that medication does not reach or penetrate the cross-linked cornea as well as a normal cornea or an infected cornea. As it is, fungal medications are not best known for their penetration. Because the collagen becomes tighter, the influx of the medication is a little less. So what happens is, if you do cross-linking to the donor cornea and there is no recurrence, then it's wonderful. But after the treatment, suppose there is a recurrence, then you have to keep it in mind that this recurrence may not go away with medication, may be indolent. So you must be prepared for a repeat therapeutic penetrating keratoplasty. So we inferred that collagen cross-linking treatment, which is done on donor corneal tissue before corneal transplantation, does have a beneficial role in reducing recurrence of infection after TPK. And both our Institute, Shankar Nethralaya, as well as All India Institute of Medical Sciences, under Dr. Namrata Sharma and Dr. Tithyal, have published these results. And in our hospital, independent researchers are also looking in the laboratory, and they also find that at the tissue level also, this cross-linked cornea seems to retard fungus a little better. So, like I already said, for that particular study, which we have extended till date, both in terms of patient follow-ups from that study as well as new recruits, we did not consciously include people in whom the infection had crossed the limbus because we did not know whether this treatment will work or not. So what happens when you encounter this? When you have a small infection which has crossed the limbus, or when you have large infections where we know that even large grafts will leave behind some amount of infection. So when you do a TPK, the rim is not totally devoid of infection, intentionally, sometimes visibly, sometimes at the microbiological level, some infection gets left back, which causes high risk for recurrence. So we went on to do an extension of what we did before. So we, at this point of time, tried to do a variant of the CXL on the donor cornea. So instead of doing it on the donor corneal button before doing the TPK, we finished the TPK in a normal fashion. Made sure that the wound is intact so that nothing goes back into the eye. And after that, we did the CXL on the donor button after finishing the therapeutic graft. So we used ultraviolet beam diameter of about 9 to 11 millimeter, depending on the size of the graft. And we also used a limbal protection ring because we sometimes use large beam diameter. So this worked when the infection was spreading to the limbus from a smaller central infiltrate. So for larger grafts, it was not possible to cover the entire graft host junction. So we decentered the limbal ring so that wherever the infection had reached the limbus or the sclera, the effect of the CXL would be directed there, and elsewhere the limbus would be protected. So basically, you can see here in the schematic diagram, the central part, the red circle is the graft which underwent the CXL, and the penumbra is the zone which has undergone CXL, which is basically the graft host junction, and the umbra outside is the area which is protected by the limbal ring. So TPK-CXL part 1 used only the strengthening effect of the CXL on the donor cornea. TPK-CXL part 2 attempts to utilize both the strengthening effect on the donor cornea as well as the sterilizing effect of the CXL on the graft host junction. We have been seeing encouraging results. We're just waiting to collate them to gather evidence, and then we shall share them with you. So collagen cross-linking treatment can be done in the form of PAC-CXL for select cases, and collagen cross-linking treatment of the donor cornea may be done before or after therapeutic PK. Though it may not be a fail-safe option, it is definitely to be considered as a worthwhile adjuvant in the treatment of microbial keratitis. Thank you so much, and thanks for the opportunity.